This is the p-value misconceptions. We've been through the concept of confidence interval and point estimates, whether risk ratios, hazard ratios, odds ratios, or risk difference or mean differences. Then we'll go through the p-value. I understand that through the years, first and second year, you've been exposed to the idea of p-value. I will not repeat what you've already learned, but I want to highlight certain misconceptions in order to avoid misinterpretation of data while working in clinical work. The first misconception is if a p-value equals 5%, the null hypothesis has only a 5% chance of being true. This is, without a doubt, the most pervasive and pernicious of the many misconceptions about the p-value. It disseminates the false, fake news or idea that data alone can tell you how likely we are to be right or wrong in our conclusions. The simplest way to see that this is false is to note that the p-value is calculated under the assumption that the null hypothesis is true. Again, the p-value is calculated under the assumption that the null hypothesis is true. It therefore cannot simultaneously be a probability that the null hypothesis is false. Let's suppose that we flip a penny 4 times and we observe 4 heads. Two-sided p equals 0.125. This does not mean that the probability of the coin being fair is only 12.5%. The second misconception is if you have a non-significant difference, p-value equals or more than 5%, means there is no difference between groups. This is again second most pernicious, vicious misconception. A non-significant difference merely means that a null effect is statistically consistent with an observed result, together with a range of effects included in the confidence interval. It doesn't make the null effect more likely, or doesn't make the null effect the most likely. The effect best supported by the data from a given study is always the observed effect. That is the risk ratio, the odds ratio, the risk difference, the mean difference. This is the point estimate. This is the observed effect in a study, regardless of its significance. The third misconception is a statistically significant finding is clinically important. This is, in my opinion, the most common misconception that people have. This is, sometimes it's true. Both are significant statistically and clinically, but it's often untrue. So the automatic interpretation, if you have a significant p-value, then the treatment is effective or clinically important, or I should give that treatment to patients. No, this is not true at all. It's not always true. So the automatic conclusion, the automatic inference is not correct. First, the difference may be so small to be clinically meaningful or important. A hemoglobin of 12 and a hemoglobin of 11 or 11.5, the difference might be significant using the p-value estimate, but it's so small that it wouldn't make any difference in life, in clinical work. The p-value carries no information about the magnitude of an effect, which is best captured by the effect estimate. That is, for example, again, mean difference, risk ratio, odds ratio. And again, p-value carries no information whatsoever about the precision of the estimate of the effect, which is captured by the confidence interval. Second, the endpoint, the outcome that we look at, may itself not be clinically important. It can be a surrogate outcome. Many trials report surrogate outcome. For example, response rate versus survival, CD4 counts versus clinical disease, change in the measurement scale versus improving functions. So, a statistically significant finding is not always clinically important because of two things, very important two things. The difference might be so small to be clinically meaningful, or the outcome itself may be extremely not relevant to patients, not important in our life, in decision making. The fourth misconception, the last one, studies with p-values on opposite side of 0.05, for example, are conflicting. This is not correct at all, absolutely wrong. You might have one study giving a non-significant result, p-value more than 5%, and another study giving a p-value, significant p-value of less than 0.05. And in fact, they are not conflicting. They have the exact same effect. When you look at the graph, you'll find that two studies, study on the left had a 10% benefit, the square in the middle. Of course, the vertical line is the confidence interval. And the second also has a 10% benefit. For example, 10% improvement in survival, 10% improvement in increase in hemoglobin count, 10% improvement in recovery from COVID-19, whatever, 10% improvement, 10% reduction of mortality in patients with COVID-19, for example. But the study on the left, the p-value is not significant. It equals 0.3. On the right side, the study has a significant p-value of 0.002. That is 0.2%. Both have the same effect, 10% benefit. But one of them is statistically not significant, and the second one is statistically significant. So this is another demo that not everything that is statistically significant is important, or statistically not significant is not important, or not clinically important. But let's focus on this misconception. When you see one study giving an insignificant result and another study giving a significant result, you might think, most of people think that they are contradictory. No, they are not contradictory. They have the same effect. The difference is only in the precision of the estimate of the effect. The left side is less precise, probably because it has higher standard error because of probably of a small sample size, among many other reasons for this. While the study on the right side has a very narrow confidence interval, probably because it has a larger sample size. So the difference here is about precision, not about they are contradictory. They are not contradictory. Both are not contradictory. Both have the exact same effect, which is 10% improvement. For a long time, people have used this kind of p-value in order to make conclusions and decisions. And for a long time, we recommended or we advised against this. But people listen to higher authority. The authority here is the American Statistical Association. It's actually scholars who belong there invented the p-value a long time ago. So they released a statement in March 2016 confessing that p-value has no value. These are two statements of the long statement by the association. That p-values do not measure the probability that the studied hypothesis is true. This kills the theoretical part of the p-value. And the second of the statements states that a p-value or statistical significance does not measure the size of an effect or the importance of a result. So what's the verdict? What's the verdict? The verdict is p-value has no value in our clinical decision making. So for example, if you want to say, does remdesivir reduce the mortality of patients with COVID-19, severe or critical COVID-19? Don't look at the p-value. Look at the size of the effect. This is the point estimate, risk ratio, mean difference, hazard ratio, odds ratio. Look at the precision of the estimate, that is the confidence interval. Look at the importance of the outcome. Is it only reduction in the days with COVID-19 from 15 days to 11 days, or is it reduced mortality or reduced need for ventilation? And put that in context of the best available current evidence. If you have all these, the size of the effect, the direction of the effect, the precision of the effect, the importance, relative importance of the outcome, putting all this in context as a part of accumulating evidence, then you can make a decision. These are the basis for making clinical decision, not p-value. Thank you. Stay safe, stay home.